Welcome to the Eye Experts University Lecture Series. I'm Dr. Eli Sluge, and today we'll be talking about Lecture 1 in Foundation of Ophthalmology, the Anatomy of the Orbit, and Orbital Adnexa. The Foundation series focuses on the very basics of ophthalmology that we will be using as a framework to then try to understand the entire specialty. In this lecture, we're going to try to learn about the bony orbit, which bones compose it, what's in the orbit, the extraocular muscles that move the eye in different directions, and how all those structures are supplied. So let's talk about the orbit or the eye socket. So the eye socket isn't necessarily round like a sphere. It's more pear-shaped. So you kind of have this big sphere in the beginning, and then it kind of tapers off towards the orbital apex. The orbit is about 30 milliliters in volume, and it is wider than it is taller. If you can think about the eyelid fissures, the eyelid fissure is again wider than the eyelids can open. So you can try to remember it that way. Now, the deepest part of the eye socket actually lies about a centimeter behind the orbital rim. And if you think about it, because you have a ball in the eye socket, which is the eyeball, you need to have some space on the margin that keeps it from popping out. That's why it's deeper, not at the edge, but about a centimeter to that edge. The orbit is again about 40 to 45 millimeters deep towards the orbital apex. And this fluctuates based on age, race, sex. We're all different people and our eye sockets are different. That's why you sometimes have deep set eyes, you have bulgy eyes. The orbital margin is composed of the frontal, the zygomatic, the maxillary, and the lacrimal bones. So let's talk about the actual orbit now. So the orbital roof is composed of the frontal bone and the lesser wing of the sphenoid. It contains the lacrimal gland and within the lacrimal gland fossa. The trochlea is about 4 millimeters from the orbital margin medially, and that is where the trochlea gets attached. So theoretically, if you poke or damage something superior medially in the orbit, you can damage the superior oblique pulley system and the trochlea. So the orbital floor is composed of the maxillary bone, which is the biggest component, the palatine bone, and then a little orbital plate of the zygomatic bone. Now, inferiorly, right through the floor, you have the infraorbital canal and the infraorbital foramen. That's where your infraorbital nerve comes through. So if you have a blowout fracture where the orbital floor is damaged, that has a high tendency of damaging the infraorbital nerve, thus causing anesthesia of that area. Now let's talk about the walls of the orbit. So the medial wall is composed of the frontal process of the maxillary bone, the lacrimal bone, the orbital plate of the ethmoid bone, and the lesser wing of the sphenoid. Now the ethmoid, again, I'd say forms the majority of it, and the ethmoid is the one that has the lamina propria. This is the largest and the paper-thin part of the medial wall. So one, that's what's going to break if you have a medial wall fracture, but also because it's so thin, if you have an orbital abscess, that is going to erode from the sinus and into the orbit through that area just because that's the smallest area to eat through. When you do your orbital dissection, if you do it along the medial wall, you will hit the ethmoidal foramina. That's where the blood vessels come through and they bleed. So when you do your dissection, you need to make sure you cauterize those or you're not going to have a very good view. The lateral wall of the orbit is composed of zygomatic bone and the greater wing of the sphenoid. Now, the zygomatic chunk is by far the thickest and the strongest, so your lateral orbital wall usually should not break. Everything else likes to break, but since there is no sinus, this is just thick bone right there, so it gives you the greatest support. It is also the source of the attachment for the lateral canthal tendon, and that's where we go when we do our LTS surgery. Now, this is an important slide with a lot of testable information. This is what goes through the various canals. So for the optic canal, it goes through the lesser wing of the sphenoid, and it's pretty easy. It just transmits the optic nerve, the ophthalmic artery, and some sympathetic fibers from the carotid plexus. Now, the superior orbital fissure is much more interesting and complicated. It is created between the lesser and greater wings of the sphenoid. And if we look at the diagram, we see that the annulus of Zinn, which is the connective tissue where the orbital muscles insert, divides it into three distinct areas. Now, the group above the annulus of Zinn contains the V1 branches of the trigeminal nerve, which is the lacrimal and the frontal branches, as well as the superior ophthalmic vein and the trochlear nerve. Now, below the annulus of Zinn, it's easy. We just have the inferior ophthalmic vein, so the veins are all outside the annulus of Zinn. Now, inside, we have the cranial nerve 3, the oculomotor nerve. We have the nasociliary nerve, which is still V1. We'll have the sympathetic fibers, and we also have the abducens nerve, cranial nerve 6. Now, again, if we look at the diagram, that's what's coming out of the orbital fissure. But if you look closely within the annulus of Zinn, that is a separate group, because if we look at all the structures that are within the annulus of Zinn, we also have the optic nerve and the ophthalmic artery. Now, where there is a superior orbital fissure, there's an inferior orbital fissure. So the inferior orbital fissure is much less exciting. It's between the greater wing of the sphenoid and the maxilla. This transmits the infraorbital nerve, the most important part, some zygomatic branches of the V2, and the inferior ophthalmic vein, which comes out of the superior but then travels over the inferior fissure. So this is the bundle that gets torn when there's an orbital floor fracture, which causes bleeding and damage to the respective sensory nerves. Now let's talk about the foramina. So the supraorbital foramina is located in the frontal bone above the orbit. That's where our supraorbital nerve and blood vessel come out. Then we have the ethmoidal foramina that we've talked about before. It's deeper in the socket, and it contains the ethmoidal blood vessels and some nerves. And the infraorbital canal is right there below the orbital rim. You can actually feel it when you palpate your cheek. That's where your infraorbital nerve comes out. Now, because we have to, let's talk about the periorbital sinuses and why they are somewhat important. So the medial orbital walls run pretty parallel, and they're the thinnest over there, the limina propria. So this is where the sinuses typically erode into the orbit and cause the infection. The lateral walls don't have a sinus, but they do have this cool 45-degree angle with the plane. Now, besides infections, sinuses can harbor mucoceles, which is just big cysts from the mucus glands that form and can erode into the orbit or through the wall. And they can also form polyps and other tumors. Now, this is interesting. Referred pain. So you can get referred pain from the sinuses, which are deep inside the head, to manifest onto the skin. So the frontal sinus is easy. It's just your forehead. The maxillary sinus is your cheekbones, which again makes sense. It's about the maxillary sinus. But the sphenoethmoidal sinus, because it's so deep in your head, it actually can manifest to the top or the back of your head. Now let's talk about the nerve that we haven't covered with the superior fissure, and the ciliary ganglion. So it comes off as the long sensory root off the nasociliary branch of the trigeminal nerve. And that's where you get the sensation from the cornea, the iris, the ciliary body, the eyeball part, basically. Next, it has the motor root, which comes off of cranial nerve 3. And these fibers then synapse in the ciliary ganglion. And then their postganglionic sympathetics travel down to the iris sphincter in the ciliary muscle. That's how we get our muscle control. And then the sympathetic fibers, they do not synapse. As we know, the sympathetic fibers have already synapsed, and they just travel through the ocular blood vessels, and they travel through the ciliary ganglion and out to the dilator muscle. The long ciliary nerves are about 2 to 3 in number. They will bypass the ciliary ganglion, and they don't carry parasympathetics. They just carry the sensory and the sympathetic fibers as they arise from the nasociliary nerve. And after they enter the eye, they are responsible for pupillary dilation and corneal sensation. In contrast, the short ciliary nerves, there's more of them, there's about 6 to 10. They do arise from the ciliary ganglion. And then they will travel on both sides of the optic nerve, pierce the sclera on the nerve, and as they enter the eye between the choroid and the sclera, they will travel to supply the cornea, the ciliary body, and the iris. Together, the parasympathetics, sympathetics, and the sensory nerves form these myelinated, fast-conducting nerves. The parasympathetics are the ones that synapse in the ganglion. The sympathetics have already synapsed in the superior cervical ganglion, so they're just passing through. And the sensory fibers are also just passing through because their cell bodies are in the trigeminal ganglion. Now we're going to talk about the extraocular muscles. Now, the reason why they're called extraocular is because there's also intraocular muscles like the dilator and the sphincter pupillae. So there's seven. Four of them are rectus muscles. The rectus muscles are the medial, lateral, superior, and inferior. They insert anteriorly to the globe and they move the eye in very simple positions, kind of like a joystick. Then there's two oblique muscles, which is the superior oblique and the inferior oblique. That's the ones that toward the eye, but because they insert behind the equator, their action is the opposite of what you would think. The superior muscle can actually push the eye down instead of up because it has a different pivot. And lastly, the seventh muscle is the levator palpebrae superioris. It doesn't touch the eyeball, but it does elevate the eyelid. Now, let's talk about the muscles' origins. Where do they come from? So, easy. All the rectus muscles originate from the annulus of Zinn. The inferior oblique, though, originates from the orbital floor, and the superior oblique originates from the periosteum of the sphenoid body. Now, if we look at the picture, we see those numbers from the limbus. So that is the distance from the limbus to the muscle insertion. If you look at it closely, you see they start increasing in a clockwise manner from the medial rectus, and that is called the spiral of Fallot. So those numbers are important for strabismus surgery because we need to know where to start looking for those muscles. And remember, the further away we get from the limbus, the higher chance retina is there. So if we puncture the sclera all the way through the needle, we may hit retina. The medial rectus, the inferior rectus, and the inferior oblique are all innervated by cranial nerve 3, the inferior division. The superior rectus is also cranial nerve 3, but it's the only one that's the superior division. The lateral rectus, as we know, is cranial nerve 6. And lastly, the superior oblique is the trochlear nerve, cranial nerve 4. Muscles need blood, right, to work. So it's convenient that the ophthalmic artery supplies most of the extraocular muscles. The lateral rectus does have a little bit of blood supply from the lacrimal artery. The inferior oblique does have some blood supply also from the infraorbital artery, and this is very testable, but the rectus muscles all carry two anterior arteries except for the lateral rectus, which only carries one. So theoretically, if you had a question about which muscle would have the least effect on causing anterior segment ischemia, it would be the lateral rectus since it only has one blood vessel. Now let's talk about the specific muscle fibers. So the skeletal muscles in the rest of the body have about a 1 to 50 to 1 to 125 ratio of nerves to muscle fibers, versus in the eye, one neuron usually gets only 3 to 5 muscles. This allows for really precise ocular control. The muscles have a slow, smooth contraction component, which is usually located more superficially at the muscle belly. That's where the tonic fibers are. And this is the on grop endings that supports this smooth contraction. Now, in contrast, the fast twitch fibers are larger than the tonic fibers and they're located more deeply within the muscle belly. These allow for fast contractions and they all fire as a single on plaque neuromuscular junction. This allows for the rapid eye movements. Let's talk about the eyelid now. The palpebral fissure is about 27 to 30 millimeters long and about 8 to 11 millimeters wide in adults. The upper lid can be raised about 15 millimeters by the levator alone, and an extra 2 millimeters can be provided by the frontalis. That's why you can see older people kind of lifting their eyebrows up to kind of raise the eyelid up a little bit more. The skin is the thinnest in the body. It's got a little fine hair, sebaceous glands, sweat glands, and it does not have a dermis. The subcutaneous tissue is loose, there's no fat, and basically once you cut skin in the eyelid, you will pretty quickly hit muscle. Now, while the eyelid does not have a dermis, it is exceedingly complicated. So the eyelid has 8 layers, so going from the anterior to posterior, we start with skin. The skin has a little bit of that subcutaneous tissue. Then we hit muscle or orbicularis. And right behind the orbicularis is the orbital septum. That's our connective tissue that separates basically the front components from the back components. Behind the septum, we have the levator aponeurosis. This is why when we do our levator surgeries, we have to open up the septum to get to the levator. Behind the levator is the mular muscle. Behind that sits the tarsal plate, or you just get the tarsal plate depending on how deep you are. And then you have the conjunctiva on the inside. Now, the superior eyelid fold is formed by the first insertional attachments of the levator aponeurosis to the upper tarsal border. A minimal or an absent superior fold is common in some individuals, especially with Asian descent. There's just a fewer levator to skin attachment. The eyelid margin is actually also quite interesting. It has several structures in it. So the gray line is the actual kind of grayish line you can see on the margin. It corresponds to the muscle of rhyolin, and it's a muscle that just stretches along the plane of the eyelid. On the anterior part, we have the eyelashes or the ciliary, about 2 to 3 rows. Posterior to the gray line, we have the meibomian gland orifices. And then on the eyelid skin, by the hair follicles, we have the glands of Zeiss, which are the sebaceous glands, and we'll have the glands of Moll, which is the apocrine sweat glands. The orbicularis muscle is basically a giant sphincter, and it has 3 portions to it, all innervated by the facial nerve, which is the antagonist of the levator. So the orbital part is the only voluntary part, acts as a sphincter and inserts into the medial canthal tendon and the orbital rim. Then there's the palpebral part, which covers the preseptal and the pretarsal portions, both of which have a voluntary and an involuntary component. So when you feel like something's coming at you and you involuntarily blink, that's the palpebral part, not the orbital part. So the main muscle that opens the eyelid is the levator, and it does this through its attachment of the levator aponeurosis. So the muscle body is about 40 millimeters long, and it changes directions from horizontal to vertical at the Whitnall ligament. The aponeurosis inserts just anterior tarsals and also medially and laterally. So it's a nice broad insertion. The fibrous elements also pass through the orbicularis, the subcutaneous tissue, and insert eyelid skin. And as we just talked about, that's what makes the eyelid fold. The mular muscle sits superior to the tarsus. It's a smooth, non-striated muscle that is sympathetically innervated. It originates on the undersurface of the levator muscle and then inserts into the tarsal plate. If we lose tone, we get about 1 to 2 millimeters of ptosis, hence why we get ptosis in Horner syndrome, because it's the loss of the sympathetic tone. It has nothing to do with cranial nerve 3. The orbital septum is a thin sheet of connective tissue that is the extension of the orbital periosteum. It keeps the orbital fat back, and because of its strong connective properties, it also keeps the inflammation separately from one compartment to the other, so we can use it to define preseptal versus orbital cellulitis. The tarsus is just dense connective tissue. It's not cartilage. It's about 29 millimeters long. The upper tarsus is about 11 millimeters tall, and the lower one is about 4 millimeters tall. Now, as we can tell by this diagram, the eyelid has a bunch of glands. So the meibomian glands are the most important. They're located in the tarsus. They're modified holocrine sebaceous glands that are oriented vertically and in parallel rows in the tarsus. The upper one has about 30 to 40, and the lower one has about 20 to 30. The oil is secreted to form this reservoir on the eyelid margin, and then it's spread with the blink reflex. This creates the lipid layer, which we need to keep our tears from evaporating. The glands of Zeiss are modified sebaceous glands of the cilia follicles. They're holocrine and oily secretions, and they make the skin oily. The glands of Moll are apocrine sweat glands. The conjunctiva has 3 geographical zones, which makes sense. It's got the fornix, it's got the palpebral part, which is the conjunctiva of the eyelid, and it's got the bulbar part, which is the conjunctiva that's on the eyeball. It's about 2 to 5 cells thick, and it's got some interesting stuff in it that we'll learn about later. The caruncle isn't very exciting. It's just a small fleshy piece of modified skin tissue in the medial corner. It's got some hair on it, and periodically it can get some cysts, nevi, and even a melanoma can arise over there. The plica similaris would be cool if we had it. It's the third eyelid. It's a vestigial organ. The lacrimal gland sits in the oral part of the frontal bone. It's got two lobes, the bigger lobe, which is the orbital part, and it's got the palpebral lobe, which is the smaller one. Now, the ducts all empty into the conjunctival fornix, about 5 millimeters above the superior tarsus margin. The palpebral lobe is the one we can see when we lift the eyelid up, especially when people have lacrimal gland prolapse. You're seeing the palpebral lobe prolapsing. Now, it is important to note that if you want to biopsy the lacrimal gland, your first instinct is to biopsy the palpebral one because you can see it. But that is incorrect because otherwise you're going to cut all the ducts. So you actually have to go deeper into the orbital one and get a piece of that. Otherwise, you are cutting off the drainage supply. Now, tears got to drain somewhere. So tears drain through the canaliculi. We'll have a superior and inferior punctum. They then drain through the upper and lower canaliculus into the common canaliculus, which then drains in the lacrimal sac and then goes down lacrimal duct. And the nasolacrimal duct drains into the inferior meatus, so everything eventually goes into the nose. That is why you can, in fact, taste your eye drops. Now, most of the people have a canaliculus that joins into common canaliculus. Some people just have it as separate, but that's not particularly important. Now, the Horner muscle is the pretarsal orbicularis portion of the lacrimal crest. That is what drives the actual lacrimal pump during blinking, because you need to blink to actually get the fluid to pump through. Now, what is the Tenon's capsule? Because most people have never heard of Tenon's unless they do ophthalmology. So Tenon's actually a layer under the conjunctiva. It is the connective elastic tissue that's around the eyeball and in which the eyeball moves. It's got what's called pulleys, which are basically tiny little suspensory structures that the eye muscles use to, again, rotate the eye within the tenons. So on the previous slide, we talked about Tenon's capsule, and it had the pulley system, but where would all of this attach to? So this is where the suspensory ligaments come in. If we look at the picture, we can see that this is pretty detailed, good architecture, almost looks like a very sturdy bridge. So this is where everything gets attached to. This allows the eyeball to move within the socket, but also to have control over where it's going to move. The most important ligaments are the Whitnall ligament, the levator palpebrae superioris will turn. We have the Lockwood ligament on the bottom, which is kind of the analog for the inferior eyelid. And then we'll have the medial and lateral canthal tendons. So as we talked about, the blood supply to the orbit is mainly from the ophthalmic artery. The ciliary arteries are no different. They arise from the ophthalmic. There is about 20 short posterior ciliary and about 2 long. They all enter the sclera lateral to the optic nerve, and then they supply the entire uveal tract, sclera, the ciliary bodies, the corneal margin, and adjacent conjunctiva. Occlusion creates ischemic anterior optic neuropathy. The blood supply to the muscles is through the anterior ciliary arteries, and they all come in pairs except for the lateral rectus, which only has one. Now, as we know, as blood comes in, blood has to come out. So from the eyeball itself, it comes out through the vortex veins. There's about 4 to 7, and they will drain the choroid, the ciliary body, and the iris. You can actually see the ampullae about 8 to 9 millimeters from the ora serrata when you do your indirect ophthalmoscopy, or if you take a fundus photo. The iliac arterial supply is pretty extensive. We have the facial system that comes from the external carotid, and then we have the orbital system, and that's the ophthalmic branch. And if you remember, that's the internal carotid. So we actually get both carotids going to the eye because of the anastomosis. So there's a marginal arcade, which is about 3 millimeters from the eyelid border. The angular artery you got to watch out for during DCR surgery because it's passing near the lacrimal sac. The eyelid has venous drainage like everything else, and it's skin, so there's superficial, which is the pretarsal system. And then there's some deep post-tarsal system that goes in the cavernous sinus. The orbit has two main lymphatic systems. The orbit itself does not have one, but the skin of the eyelids do. So the medial group drains into the submandibular lymph nodes, while the lateral part drains into the preauricular lymph nodes. The lateral group is bigger, so when you have adenoviral lymphadenopathy, you get preauricular lymphadenopathy.